Good evening, everybody. Thank you so much for attending the 38th Annual University Faculty Lecture. I have to admit I was a little concerned about the timing today, that people might be a little bit partied out in terms of the events of this last week, but I think it's a real testament to the importance of the work, the importance of the topic, and the amazingness of the speaker, that on this very chilly night, after a very exciting week, that this is an absolutely packed crowd. And I'm just so incredibly proud of us that are all here. Each year, the University of Washington, a University of Washington faculty member is selected by his or her peers to deliver this lecture. And it's the highest recognition the faculty can bestow upon someone in their ranks. It honors faculty members whose achievements have had a substantial impact on their profession and beyond. Past recipients include artists, musicians, historians, social, natural, and physical scientists, and engineers. Some of them were even Nobel laureates. So this is a very esteemed crowd that you're entering into. Our speaker this evening is Dr. Stephen Gloyd. He's a family practice physician who's been a UW faculty member since 1986. That was the same year I entered the faculty, so good vintage. He worked for more than 30 years in Africa, Latin America, and Asia as a clinician, manager, researcher, teacher, and policy advocate. And at the UW, he teaches about the history, political economy, and management of global health from a social justice perspective. Professor Gloyd is Associate Chair for Education and Curriculum in the UW's Department of Global Health, where he directs the MPH and PhD programs. In 1987, he founded Health Alliance International, a nonprofit that's worked for decades with the health ministries of Mozambique, Sudan, and a number of other countries. He received his BA and MPH from Harvard University and his MD from the University of Chicago. And then he completed his family medicine residency as the UW, so he's always been moving up. His many awards include the UW Distinguished Teaching Award and the Edward K. Barsky Award for Global Health Activism. I could go on and on about Stephen and his work, but tonight I think it's best to let Professor Gloyd do the speaking about a very timely and important topic, achieving health for all in the 21st century. He'll discuss how, despite remarkable advances in global health over the past 3 decades, there remains an enormous gap in health worldwide. So please join me in welcoming our university faculty lecturer, Dr. Stephen Gloyd.
Thanks very much, Anna Mari, for your very generous and kind introduction. I'm pretty blown away by this honor. It's sort of like when you first go to college and you wonder if they made a mistake, in picking you, and you kind of look around and see everybody's smarter than you. But I'll take it. And I want to start out by thanking a bunch of people. First of all, I want to thank you all for coming here. It's an amazingly packed house, and I can't understand why everybody would be coming out now, but that's pretty cool. I want to thank President Young and Provost Cauce and the selection committee for their involvement in the process of selecting the university faculty lecturer. My faculty colleagues, Dean Frumkin, and a number of faculty colleagues have helped me quite a bit in not only, I think, singing my praises, I think, appropriately or inappropriately, but I think more to the point, have helped me try to figure out how to address some of these complex issues of global health and what we do with it. In particular, Matt Spark, King Holmes, Judy Wasserheit, Amy Hagopian, Steve Bajrutska, people from Health Alliance International who, when one thinks of awards that go to people for their work, my work is not work that I do myself. My work is work that I do with groups of people, particularly with Health Alliance International and the University of Washington. James Pfeiffer, Mara Child, and the whole group have been incredibly supportive and helpful, as well as the staff of the Department of Global Health and the students. I think, as you all know, being at a university, the interaction that one gets with students, particularly the students we have in the Department of Global Health, are students who come from all over the world and bring in a huge amount of understanding and day-to-day knowledge of what's going on in the world. And frankly, more than half of what I've ever learned about global health comes from my students. So a big thanks to them. And then finally, a big thanks to my family who have come from far and wide, my parents, my siblings who have come from as far as Albuquerque and Marysville, and then my wife, Awa, who both has been an inspiration to me for a long time, as well as helped me write this talk. So thanks very much. Finally, just a big thanks to the Seattle Seahawks. What they've done is that they've not only made this an incredibly exciting week, as Anna Maria was saying, but they've been a really beautiful distraction to somebody who's totally nervous about a speech, and I could, in fact, spend most of my time watching the game and watching the parade with another 700,000 people. So thanks. It's a really also an exciting time to be involved in global health. It's exciting to be working because there's a huge interest in global health. Incredible achievements that have taken place over the last while, and a fair bit of controversy. And I want to start out with that little bit of controversy by a quote from none other than Bill Gates, who said that by almost any measure, the world is better than it has ever been. People are living longer, healthier lives, and by 2035, he said, there will be almost no poor countries left in the world. He also said that you might think that such striking progress would be widely celebrated. But in fact, Melinda and I are struck by how many people think the world is getting worse. And then at the same time, not exactly the same time, but just a couple years earlier, and I think this is still true, Dr. Margaret Chan, who is the Director General of the World Health Organization, said that the differences within and between countries in income levels, opportunities, and health status are greater now than they've any time in recent history. Something has gone terribly wrong. Now, these two people are two of the most influential voices in public health, and yet they have remarkably different ideas about where we are in global health today. And what I'd like to do in the 40 or so minutes that I have today is to try to dissect, to try to understand a little bit about those two views of global health, both of which I think are true, and to understand how we can build on our achievements and how we can begin to address some of the challenges that both I've seen and many other people have seen through our years of working through global health. So what I want to do in this period of time is to basically talk about the achievements, not just the recent achievements, but some of the old achievements, because some of those are just as important as the newer ones. And then to talk about the challenges, and particularly the challenges that have to do with issues that are pertinent and related to the United States. Many of us here most of us here are Americans, and I want to talk about what we can do here as global citizens and here as members of a country whose policies are carried out in our names. And particularly policies around neoliberal globalization, or wars, neoliberal globalization, which include austerity policies and trade agreements, to talk about and to celebrate what I would consider is a recent focus on inequality, which I think is an aspect of the change in paradigms and thinking that's occurred in the last 5 to 10 years. And then to figure out what are the kinds of things that we might be able to do given all this knowledge that we have. I'd like to start with a quote from Nelson Mandela, who is an old hero of mine, and I think celebrating what he did in his life is is related to the way that he was able to encapsulate some of the great issues of our time. And in 2000, I think he did a very nice job of encapsulating some of the issues around globalization. And he said then that we welcome the process of globalization. It's inescapable and it's irreversible. However, if globalization is to create real peace and stability across the world, it must be a process benefiting all. It must not allow the most economically and politically powerful countries to dominate and submerge the countries of the weaker and peripheral regions. And what I'm going to be suggesting to you is that much of the globalization, which I'll define in a bit, that we term as neoliberal globalization, is a globalization that has tremendous positive impacts, but some pretty serious negative impacts that are major drivers of global inequality and problems in global health. So what I want to do is start out with some achievements. As I said, old and new achievements. And I'm going to do this with some stories. And the first story I want to tell is a story of a friend of mine, somebody who works for Health Alliance International, whose name is Florencia Floriano. And she's a wonderful story of what's happened in the past in the country of Mozambique, where she's from, as well as what's happened in the last 10 years, where she's a true success story. Florencia was born in the 60s, in a country that just became independent about 8 or 10 years after she was born. She was born in a family with a mother who had mental illness. Her father wasn't around, and she was raised for a few years by her grandmother, and then she was raised in an orphanage. And when you're raised in an orphanage in rural Africa, your opportunities aren't very great. And she was in a situation where, because of the newly independent Mozambique, which occurred in '75, she was able to use some of her earlier education to jump on to an effort in the country of Mozambique where they put enormous amounts of resources and energy into educating the entire population. Immediately after independence, every school was completely filled. They were building new schools all the time. If you had a 4th grade education, you were teaching schools in Mozambique because it was that important. She was able to get an education. She got into nursing school, was able to finish nursing school as a nurse midwife, delivered babies for several years, was able to do lots of training in the community with community health workers, etc. And by the late 1980s, she was already directing the entire maternal child health services of a province of Mozambique of about 1 million people. And in fact, she was the director of this when HAI began working in Mozambique in the late 80s, and that's how we got to know her. She was somebody who was well known at that time throughout the country. She was also raising her 4 children. In 2002, her husband died of tuberculosis, which later turned out to be AIDS. And so very shortly thereafter, she tested herself for HIV and was positive. And during that period of time of her positivity, most of the people who became positive in Mozambique in 2002 were looking at a death sentence. They were looking at a series of long, painful illnesses that would inevitably result in death, and there was nothing that could be done about it. In spite of the fact that at the same time, from 1996, that AIDS treatment, triple therapy, had been completely available to people in rich countries, including the United States. So she was in a situation where she was quite concerned, but things were changing. Things were basically with a series of activist groups, both in this country and around the world, some aspects of HIV treatment began to change. At that time, HIV treatment cost between $10,000 and $15,000 per person per year. And most people who were in the public health community here in this country, as well as elsewhere, would say, it really doesn't make any sense to treat people in Africa for AIDS. In countries like Mozambique that were able to spend $5 per person per year for all illnesses, to spend $10,000 to $15,000 for HIV made no sense at all. Now, we knew at this time that the prices were elevated. and were not representative of the real prices. And in fact, a tremendous amount of work, advocacy work, began to occur in many countries around the world, in Brazil, South Africa, in some countries of Africa, where there were pressures to take drugs from people who hadn't used all their drugs and start treating people. This was done by Paul Farmer with his group in Haiti. And very slowly, the dialogue, the thinking around HIV was, well, maybe it is possible. But at the same time, the public health community, even in this country, would say, well, it's not only too expensive, but we don't have the systems to be able to care for a complex and chronic disease. We don't have a population that's going to be able to adhere to the drugs. We're worried about that this will take all of the focus from prevention, and we know that prevention is more cost-effective than cure. And there were some people who were worried about the fact that maybe if people started taking antiretrovirals, they would lose their inhibitions, or they would lose their sense that they had to be protective about their sex. So at that time, the public health community was basically saying, you know, it's pretty expensive, but we really can't do very much about it because it doesn't make sense anyway. But with activism that was right here in Seattle with HAI, which I'm very proud of, with the University of Washington, with 600 NGOs in Brazil, with people from around the world, things started changing. Brazil was forced as a country to start treating HIV as a national policy, and therefore they had to figure out a way to make drugs. They started making drugs against the pressure of the US pharmaceutical industry at that time and the US government, which in fact came down on Brazil. South Africa began to move in that direction, and slowly but surely things began to change. One of the biggest things was Harvard University put together what they called a consensus statement that was signed by 130 or 140 faculty members at that time, where they basically said that in this time, it makes no sense for us not to move forward with AIDS treatment from a standpoint of human rights. That people shouldn't die because it's more cost-effective to do something in a preventive way. This began to change, folks. The Harvard statement influenced Kofi Annan. The UN had a big General Assembly. After the General Assembly, there was the Global Fund for AIDS, Tuberculosis, and Malaria was formed. Shortly thereafter, the Clinton Foundation went to 4 countries around the world and said, I will raise as much money as is possibly necessary to be able to have universal treatment for HIV. Then the 3x5 initiative from the World Health Organization came about. And then finally, President Bush, in the best thing that he did during his presidency, announced the formation of the President's Emergency Program for AIDS Relief, or PEPFAR. And the funding for HIV went from $300 million a year to $3.4 billion a year in a period of about 4 years. This was incredible. We'd never seen anything like this before. And what happened was that Flora, was positive for AIDS just at the time that this was happening. And she didn't believe it, just like so many people in Mozambique. And I remember she actually asked me to talk to her kids to be able to tell them that she was positive, because she was worried about what she was going to say to them. And I was able to say, well, I think that we're going to be able to have the possibility for treatment, but I wasn't sure. But things were changing, and things changed so rapidly that by the time she got into treatment, 6 months later, the country of Mozambique developed a national AIDS treatment program. And now virtually every country in sub-Saharan Africa has national AIDS treatment programs. These programs are treating 60–70% of all the eligible people who have HIV, and it's an incredible success. And what's happened with this is that success has begun to spin over, and it's spun over to other diseases, where we're beginning to think not about just the cost-effectiveness of addressing diseases, but about the right to treatment, about health as a human right, and not looking at the world through the lens of resource scarcity, but looking at the world through the lens of rights and what is a morally appropriate thing to do. This was an incredible time and amazing transformation. Flora began taking antiretrovirals, 1 pill in the morning, 1 pill in the evening, and she's been doing this since 2002. I just asked her today, by the way, what her CD4 count was. It was 170 during the time that she was there, for those people who are doctors. It's a very low count, which is actually in the category of AIDS. It's 750 last week, and I was so pleased. So the success story here is not just one person, but literally 10 million people who are now on antiretroviral treatment because of a shift in thinking. Not because of a change in science, because the science was there in 1996. But the change in thinking is what made a difference. So the achievements here that I want to talk about are two lessons from this. One is that an expansion of global health interventions can be possible through not just science, but through global health advocacy. And we as university people, we as community people have to realize that science is only part of the story. And that rights-based treatment has a huge role to play. And in fact, the world is beginning to move away from the cost-effectiveness idea and towards a rights-based treatment, which is something we actually had a number of years ago. And then finally, spin-offs to other conditions, so that when we think about HIV treatment, we think about, well, we can do this with TB, we can do this with malaria, we can do this with maternal child health issues. So this really is a time that I think we can support Bill Gates in what he says, is that we've moved in a way that really was unimaginable before. The other lesson I think that we can say that's an achievement is to go back and remember how Flora was able to get to where she is. And that she had a quality public education, she had job opportunities, she had health care, she had a safety net, and these were the kinds of things that could be used to take somebody who was in extreme poverty with all of the conditions that you would expect her not to be able to survive. And she's not only survived, but doing very well. And she has 4 kids in college right now, which is great. Now, what I want to do a little bit is to go to my own story for a couple of reasons. One is that many of you have taken my classes, so I don't want to teach the same stuff over and again. But I also wanted to tell a little bit of my story because I think it helps me understand some aspects of how healthcare has moved over the last 30 years and the kinds of things we can learn from what happened 30 years ago and what's beginning to happen now. Because I think, as you'll hear, that in many ways our thinking about healthcare has gone full circle in that last 30 years. As Anna Mari said, I did my residency here. I also did high school here. I'm a Seattle guy. I graduated from Roosevelt High School. And when I came back to Seattle after doing my residency, having been somebody who was in high school and college during the Vietnam War, I was a bit of an activist, like most of my colleagues, and that much of my view of the world came about from trying to understand what the role of our government was in terms of some of the wars and some of the activities that we're involved in. So I was an activist, both in terms of anti-war activists for what we were doing in particularly Vietnam, became involved in anti-apartheid activities here in Seattle. And then I had this opportunity to play African music simply because I played music before in high school, and I heard a band and I loved it. And one of the things you can do when you've just finished your residency and don't have another job is you can just start playing music. So I did. And I played in an African marimba band, which was from Zimbabwe. And we quickly, because we were involved in anti-apartheid work, started developing a program to help the freedom fighters who were fighting for independence of Zimbabwe, which at that time was Rhodesia. So we created this group, started sending clothes, we started sending money to Mozambique, where some of these freedom fighters were operating. And I learned about Mozambique during this period of time. Mozambique had just become independent, like I'd mentioned before, and it was a country that had not only thrown off its Portuguese colonialism that they had for 500 years, but it was a country that was engaged in what I would call a socialist experiment in equity strategies. And that socialist experiment in equity strategies was one where the way the government tried to develop the country was based on justice, was based on equity. They learned from the experiences in China, from experiences in Cuba, from Kerala State in India, and some other places in the world, where if you can provide health for all, education for all, if you can provide food, nutrition, the kinds of conditions that really can provide a safety net, that you can make huge progress in a short period of time, which is what happened in these other countries. So they expanded their schools, they expanded their health care, they developed land reform, They had rules for living wages in companies. They had rules for work conditions. And, you know, I'm not saying this was a Shangri-La because we had lots of problems during that time and it wasn't all perfect, but there was an effort to address these things, and particularly women's roles. I remember at a May Day celebration once that the tractors were all driven by women in 1979, which is pretty amazing when you think about it. So things were pretty incredible during that period of time. And in fact, Mozambique became kind of a model for primary health care. The primary healthcare story at that time was that a number of countries in the world, led by China and the Soviet Union at that time, were developing this conceptual framework that health should be a right, that we should focus on these social determinants of health, like education, like healthcare, like water, sanitation, land reform, jobs, etc. And the other thing that they put out at this time was that governments have responsibility for health, that particularly for the poorest of the poor, that the private sector is really not going to get out to the places where the poor need health care. So that there was an explicit aspect of primary health care and the ideas of primary health care of government responsibility. They talked about international cooperation during that period of time, and the idea of international cooperation was that international cooperation was needed not just for the idea of providing aid, which was certainly one of the pieces of cooperation that was important, but it was also important for the idea of cooperation economically and to reduce the amount that the North would exploit the resources of the South. Because at that time, and still today, there's a fair amount of exploitation in terms of the North taking minerals, taking lumber, taking other aspects of the resources from the South, and the South doesn't get their fair share oftentimes. And then to reduce wars and military spending. So as you can imagine, this was pretty exciting. I learned about this. I wasn't exactly fully employed at the time, and I thought, wow, this is cool. It sounds like a really great opportunity. And some people from Mozambique came to Seattle at that time as part of a labor union group, and they talked about the fact that Mozambique had 40 doctors for 11 million people, and that they could use some doctors. So I thought to myself, wow, that sounds pretty cool. So I wrote a letter to the Ministry of Health, just like anybody would do, right? And just like you would expect, I got no response for about 7 or 8 months. Then I heard about somebody who heard about somebody else, and got sort of a network going. And finally, somebody actually knew that I had my letter and my CV on somebody's table. So 8 months later, I get this contract in the mail, written in Portuguese, which I didn't speak at the time. And so I looked at it, had somebody translate it for me. Thought it sounded pretty good. It told me how many times I had to have call and and emergency room, etc. So I signed it. I was earning, my salary was $650 a month, which was, not bad. And so I sent it away, and about 2 months later, after, again, kind of wondering what was going on, I get this ticket in the mail. And so, without any other communication with the Ministry of Health. So I ended up, telling my parents. My dad probably remembers this, that, this is what I was going to do. They were, of course, totally blown away by their son wanting to do this. So I ended up going to Mozambique in early 1979, and I spent about 4 years there, a little less than 4 years, and I worked for the first couple of years in a district where I was the only doctor for about 75,000 people, and then I worked for another couple of years where I was the only doctor for about 150,000 people. And so you can imagine it was fairly daunting. You kind of worked 7 days a week, 24 hours a day, but you figured out ways to deal with it. But it was incredibly exciting, because what happened is that even though there was a lot of work, there was a tremendous amount of joy in the work that one did, because there weren't a lot of people who were able to do, there weren't enough nurses, there weren't enough doctors, that everybody collaborated. We used to have collective work twice a week, where we'd get up at 6 o'clock in the morning and we'd have to sort of clean either the health facilities, or we'd go out back and we'd cultivate places where we could make food, or we could grow food for the hospital. Very exciting time. One of the things that was really interesting is we had an essential drug system that was run buying generic drugs, and we had drugs literally for everything that we needed. It was pretty amazing. We only had a list of about 400 drugs, but that was all we needed. We also had a situation where that there was so much interest in schools that I was talking about before, is that most schools in most towns were open for 3 cycles per day of teaching. So schools would start at 6 o'clock in the morning till about 11:30, and then the next cycle would be about 12 to about 4 or 5, and I probably have this wrong, but then the next one, what I remember is that they wouldn't end until 11. So you could go to any small town or even a village in Mozambique, and you'd find people going to school at 11 o'clock, oftentimes people who were in their 60s, 70s, and even older, who would be wanting to go to school because this was the opportunity. It was an amazing time. And it was a time that made us all feel like things were possible. If you look at, and I show this to some of my classes sometimes, if you look at World Health Organization mortality figures, child mortality figures from 1970 to 75, from independence and then until about 78, 79, 80, they dropped precipitously, the mortality rates. Now, we're not sure if that was really for what we were doing, but it certainly seemed like something was happening. Then what happened during that time is what happened, it was sort of emblematic of what's happened in many parts of the world. And that's the war. And this is one of the reasons I want to talk about wars, is because at that time, Mozambique was also doing some things that many folks here in the United States and many folks in Southern Africa didn't like. Mozambique was supporting the Zimbabwe freedom fighters, which is one of the reasons I got there in the first place, of course. And they were supporting the African National Congress of Nelson Mandela. And of course, Nelson Mandela was a terrorist as far as the United States and South Africa were concerned. The Rhodesians didn't want to have anything to do with their support of the freedom fighters. So back in about 78, the Rhodesians started bombing Mozambique, sending troops into Mozambique, and they created this proxy army that was really Rhodesian soldiers that were paid to be able to fight this war. Zimbabwe became independent in 1980. The war stopped. Then in about 81, the South Africans took over, and the war started up again. Again, proxy army, South African army. Why did they fight this war? Well, part of it was the support of Zimbabwe, Mandela, and the ANC. The other piece of this was that they were fighting this war because Mozambique was an experiment of socialism that was an anathema to the thinking of many of the people who were involved. It was an example of primary health care that didn't include privatized health care, regulating businesses, regulating investments, regulating capital flows, basically doing what it could to keep the resources of the country in Mozambique. Now, that didn't mean that there was very much foreign investment in Mozambique, but whatever investment there was in Mozambique stayed in Mozambique. But this is not something that the United States nor South Africa were particularly pleased with. So they created this proxy army to destabilize the country. And over a period of 14 years, with this break in the middle, over 1 million people were killed, mostly civilians. The disability was enormous, particularly with landmines. I used to see 1 landmine accident per week when I was working there. Destruction of infrastructure. 600 of the 1,200 health posts were destroyed purposely as an approach to undermine the credibility of the government, because much of the popularity of the government was based on their health and their health services. They destroyed infrastructure where they would destroy schools as well. This obviously undermined government programs tremendously. They succeeded over this period of time, and when you've ever been involved in a war, you know that people just get tired of wars and will do anything to get out of a war. And so by the time 1990, 91, 92 came along, there was essentially no interest at all in fighting a war for any reason. All people wanted was peace. So at that point, the rebels, if you will, this proxy army, and the points of agreement were enough to force Mozambique to drop its equity strategies, and it ceased becoming a socialist country at that time. So in fact, the proxy army won the war simply by outlasting things. After I left, by the way, to finish the story in Mozambique, one of the reasons that HAI got formed in the first place was when I came back to the US during the war, we actually created this organization that started out as a solidarity organization to support Mozambique against the war effort. And we did this for the first 5 or 6 years of the organization until the war stopped. When I got back to the US, I got involved in Central America human rights work and health rights work, and would take trips pretty frequently, a couple times a year, to Central America. And one trip I took was to Nicaragua. And I want to tell you a little bit about what happened to me in Nicaragua. I was there basically looking at possibilities of collaborating with Nicaraguan universities. I was just joining the faculty, just to join the faculty here. This was in 1986. And when I went there, we went to a hospital in Jinotega, which is in the sort of northern part of Nicaragua. And we'd heard on the way to Jinotega that there was a family that had just been essentially attacked by a group of Contras. And if people remember that there was a war in Nicaragua that was fought from the late 80s until about 1990, there was a war that the United States started in supporting a proxy army for the US called the Contras. And the Contras were short for Contra Revolucionarios, or counter-revolutionaries. And when I went up to Jinotega, trying to see what was going on, I remember walking in a hospital and passing this nurse who was holding this 20-month girl whose arm was shot off. And that was Luz Mabel, who was 20 months at that time. The story of Luz is that she was in her house with her family. A group of Contra soldiers came up to her family, to their house, threw a grenade in, because they had grenades because they were supported by American finances, opened the door and essentially gunned down with automatic weapons the entire family, killing the father, killing a son, and wounding all the rest of the family. The mother was shot, a couple of the other kids were shot. The mother and Luz were in the hospital, so we talked to them, and they told us the story about what happened. And it was a pretty horrendous event. It was a horrendous event not just because of what happened to this family, but also what it represented in terms of what I had seen in Mozambique just a few short years before. And what I want to talk about is the war in Nicaragua, and to give you a sense of how it was fought and how so many of these wars tend to be fought. Nicaragua was also thought of as a threat to the United States. President Reagan at that time had called it a threat because they had a Sandinista government, which was a leftist government, and again was involved in equity strategies. It was supporting nearby liberation movements in Guatemala, El Salvador, and Honduras. And it was an example of a social experiment, as I mentioned, regulating sugar, bananas, mining interests, really with the idea of reducing the ability of these corporations to exploit populations. They created a proxy army with the idea of destabilizing the country. Most of the knowledge about the Contras comes about from our thinking of the Iran-Contra affair and all of the stuff that was related to Iran. But what happened in Nicaragua, to me, was a fundamental example of the kinds of things that we were doing at the time, and what I would suggest is that we are still doing to some extent. In Nicaragua, 40,000 people were killed with this war, which was a war that was fought very much in the way that Luz's family were exposed to, which was essentially terrorizing the countryside, because terrorizing a countryside would reduce the chances of people wanting to continue and particularly supporting the Sandinistas. They undermined government programs. They shattered the dream in the same kind of way, particularly because they destroyed the infrastructure. They succeeded in undermining government credibility. People got very, very tired of the war. And then they forced, well, during the next election, the Sandinistas lost that election with a great deal of U.S. support of the opposition. And we don't know what the U.S. did. WikiLeaks weren't around during that period of time. And then the Sandinistas, in fact, were re-elected back in 1996 and have been in and out of power since then. Again, a country that was trying to do two things, trying to develop equity strategies and at the same time trying to rein in some of the control that had occurred with investment from the outside, particularly investment from American companies. And when American companies' investments are threatened, they usually have friends in Washington, and those friends in Washington can make wars happen. So the situation in Nicaragua was one that was particularly problematic. And if you look at both of these together, you think of that, well, wars have a huge impact on public health. And when we think about global health, it's almost not on people's radar. Here in the University of Washington, we did have a conference on war and health. We're actually thinking about putting a course together in war and health. But overall, when you look at textbooks about war and, around global health, war doesn't appear as a big piece of it. And yet, if you look at the deaths and disability, Emmanuel Gaquido and her colleagues at the Institute for Health Metrics in the Department of Global Health have estimated that overall, over the last 20 years, that approximately 400,000 people are killed every year directly by war. And that's not counting the social economic disruption that occurs as a result of these wars. These wars are tremendously problematic. They divert resources. Ministries of health budgets and education budgets start going down because you can't do very much with what's left. And of course, so many of the schools and the clinics are destroyed. There's a problem. And then you have what we call free market militarism, which is the kind that we saw in in Mozambique and in Nicaragua, where a big piece of that war was essentially to protect what we would call the vital national interests of some country whose companies, whose corporations were investing in that country. And when those investments are threatened, as they have been in Guatemala or they have been in Iran or other places, that we're quite likely to go in and fight. And when you think about that, this happens pretty often. William Bloom published a book about U.S. interventions and coups that were supported by the United States since World War II. And he listed over 70. I've just listed the 33 or 4 that are memorable to me. And I find this slide one, I mean, this is not a slide to memorize, but it's a slide to look at and to say, wow, that's a lot of interventions. And these are just American interventions during that period of time. So if you think about this, this is a huge number of interventions. And this doesn't even count what was going on before World War II, when the United States was constantly intervening in Central America and in other countries in the Caribbean and Latin America. The other thing about this list that I find interesting is that many people think, well, this is just the Cold War, you know? Because in the Cold War, we were fighting communism. So, of course, we had proxy armies because our proxy armies were dealing with that. But then you say, well, the Cold War, excuse me, but the Cold War ended in, 89, 90, but it's still going on. And I didn't put this, I guess I could have included in a coup, that in 2004, people may remember that there was a coup in Venezuela against somebody we didn't like, Hugo Chavez, who was criticized in the New York Times of trying to bribe his population by providing education and health care. That a coup that was supported by interests very close to the United States took him out of power, but there was such a popular revolt against that that they put him back into power. But the United States was behind the coup. For several days, we didn't say anything because we wanted that coup to succeed, but it didn't. Less well known is the coup of 2009 in Honduras, where the president of Honduras was overthrown. He was overthrown, again, by interests allied with the United States. President Obama, during that period of time, said that it was a coup, and basically said the United States was against that coup, but after about a week, started negotiating with the coup leaders, because it was very clear that the coup leaders had very strong interests in the United States, who had very much power within Washington. And that coup, and Zelaya, who was the president who was deposed at that time, was never allowed to come back to power. So this is still happening, and I think it's really important to realize that this kind of war effort is something that is particularly problematic and relates to 2 things. One is the direct disability and deaths that are caused by wars, and secondly, by the social disruption and what we call free market militarism. Well, since about 1980, and one of the reasons those numbers of wars have dropped a little bit is that we get into the second piece of what I'd like to talk about tonight, which is neoliberalism and the rise of neoliberal globalization. When Ronald Reagan was elected president, he was elected president on an anti-governmental platform, which the Republicans since then, and many Democrats, have embraced, where he said during his inaugural address that government is not the solution to our problems, government is the problem. And what this was a clarity around what I would call neoliberal globalization that we really haven't seen since then. I'm borrowing from Matt Sparks' book on introducing globalization, where neoliberal globalization or neoliberalism has basically 10 policy norms, and I want to define it for you just so you get a sense of what it is, because it relates to what we talked about with respect to war, and we'll talk about this with respect to trade as well. Is that what neoliberal policy norms are all about are what I would say are two essential things. One is supporting a laissez-faire free trade unencumbered by government regulations, which we know is a point of view that is espoused pretty frequently here in this country today. And the second piece of neoliberalism is cutting governments, is reducing government's role, so that governments don't do the kinds of things that governments might have done before because of some of these principles. And the principles are like trade liberalization, which is about expanding the degree to which free markets can work, but cutting public spending, deregulating business and financing, so therefore reducing the capacity of governments to regulate, privatizing public services, reducing taxes so governments don't have the same amount of resources and finances to do what they need to do, deunionization, export-led development, encouraging foreign investment, reducing inflation, and enforcing property rights. Now, this is not all anti-governmental, but many of these aspects of a neoliberal approach to developing the economy are explicitly either anti-governmental or encourage the reduction of government responsibility. And so remember, this is quite different than what we were talking about in the 70s and 80s around primary health care, where we're really talking about the government's essential responsibility for health care. So what happened in the 80s, and I talk about this a lot in my courses, so apologies to my students who have heard this over and over again, is that in the 1980s, that because of a number of factors, most of which weren't related to the countries specifically, that they were involved in debt. They got involved in debt because of increasing in interest rates, price of oil going up by the OPEC cartel, gold off of or the money off of the gold standard, subsidies for products in the United States, a number of different factors which essentially created a debt crisis throughout the world. And in virtually every country of Central and Latin America, and in 33 countries of Africa, that the International Monetary Fund, along with the World Bank and along with the US Treasury, went to these countries and said, you guys are in debt, we'll get you out of debt. We can take care of this. And we can take care of this by offering you a readjustment of your economy so that you can encourage the private sector to flourish, and then at the same time to be able to support repayments or payments of your debt scheduled over a longer time. And these policies, the structural adjustment policies, called SAPs, imposed to address the debt since the 80s, comprised of three specific areas. One was to cut the government spending, again, very neoliberal, improving terms for foreign investment and privatization, and then rescheduling the debt. And so what happened was that health ministries had their budgets cut, oftentimes by half in these countries. Education was cut. Subsidies were typically cut. Subsidies for food, so school food subsidies were cut. Transport subsidies were cut, so poor people couldn't get to work. That you had all sorts of subsidies that had been really important in the social safety net. And when they were cut, there were massive riots, there were demonstrations in many places of the world, but they were largely unheard of here in this country because, who cares about what goes on in Zimbabwe or in Central America. Improving terms for foreign investment, reducing taxation, regulation, wage decreases, reducing protections for labor and the environment. Again, reducing the ability of the governments to be able to raise the resources necessary to be able to do the kinds of things that governments do, particularly to develop equity strategies. And then finally, privatization of banks, schools, healthcare, key industries, plus market regulation of prices, and what many people call a commercialization of healthcare, so that they would charge user fees for services that used to be free, etc. This was imposed across all of these countries, most poor countries in the world, and what happened is that they weakened health systems tremendously. And what we're seeing today, and what some of the big problems in healthcare today, in spite of huge amounts of international aid, is that we have incredibly weak health systems. And these weak health systems aren't weak health systems because of what happened in the 70s and the 80s, or the 70s. They're what happened because of structural adjustment programs. These are weak health systems that come about principally, or at least largely, because of some of the policies that have come from these structural adjustment programs, which are also called the Washington Consensus. And what they are is that the budgets were slashed so that you have poorly maintained and equipped health facilities, you have inadequate transport communication, weak procurement, distribution of medicine supplies, and inadequate workforce numbers. Inadequate workforce because the budgets were cut so much that it was impossible for countries to be able to pay the numbers of workers that were required. So Mozambique and Nicaragua and some of these countries had plans to increase their workforce. Once the structural adjustment programs came in, they could no longer do it. So if you look at the distribution of doctors and nurses around the world, these are doctors, nurses per 100,000. WHO has a standard of 20, which is a pretty minimal standard because Cuba has almost 600 and the USA has over 250 doctors. 20 is a pretty small number, but look at these numbers in the countries of Africa. Same thing with the WHO standard for nurses. Look here, these numbers, and very, very low numbers. And when any countries would try to change things, like, for instance, Mozambique, they had a nurses' strike in 1991, 92. The Ministry of Health supported their strike. They wanted to increase the salaries of nurses from $21 a month to $24 a month. And what happened is that the Ministry of Health supported them, but the International Monetary Fund and the World Bank said, no, you can't do this. This is inflationary. It's beyond what Mozambique can afford, and we don't think you should do that. After months and months of haggling, they finally came up with a solution. The solution was, yes, we can go to the $24, but you have to have a cap of all of your health workforce or your nursing workforce for the next 10 years. So from 91 until 2001. And that's what, and so you see, it's very clear. Mozambique has 21 nurses, as even compared to Malawi and some of these other countries. This is a slide that one of my students, Deirdre Woolley, helped me make up, analyzing some of the effects of structural adjustment programs in Tanzania, where from the 30s until about the 70s, even through colonialism, there was a constant effort to improve education, and this is the percent of females without some education. So these are with some education. So the numbers of people without education was less and less and less throughout this period of time. And then as soon as the structural adjustment came, you see this kind of effect. You rarely see this kind of this effect in healthcare. In Nicaragua, where they had the Contra War actually had less impact on some of the health indices than the structural adjustment programs, where at this time there were fewer people who were able to go to school. So the legacy of the structural adjustment programs is there are fewer government resources because of reduced taxation, reduced currency controls, lots of capital flight because they couldn't regulate these kinds of things. It took the focus off of the equity strategies so that for years before this there was a focus on the equity strategies. It didn't stop, but it just made it very hard for many of these countries to be able to adopt them. So education, the quality and the attendance has gone down so that in very many places of the world, you actually have people still going to school, but the quality of schools is so low that people who have any income at all will send their kids to private schools. And so if you go to a public school, you don't have any possibility of having chances like Florencia had. Healthcare, we've talked about healthcare. Water sanitation, we've had very poor progress, particularly in urban areas where we've looked at some of the data from 1990 until 2010. And in fact, across all of sub-Saharan Africa, there has been no improvement in urban water supply in that last 20 years. And this is at a time when we're making these incredible improvements in health. So it's actually very, very concerning. There are job losses from foreign competition, and the overall poverty rates have increased from 80 to 2005. This is a graph that we put together on poverty, again, from World Bank numbers, looking at global poverty levels. This is the percent of population when living in households per person with incomes less than $1.25 a day. Okay, and so obviously this is the extreme poverty category, and in this category, what you can see is globally it's going down pretty well. So it kind of fits what Bill Gates has said. Latin America, Caribbean, it's been pretty flat, but it's always been low, and then just since 2000 it's starting to go down. Look in sub-Saharan Africa. If you look from 1980, the poverty levels actually increased, which is really unheard of in this area. They increased for 15 years until they just started coming down, and here in 2010, we're only barely short of 50% about where we were in 1980. That's not a very positive picture in terms of where we are. Finally, I want to talk just a little bit about free trade agreements. Now, free trade agreements, this gives you a little bit of an idea of what they're for. And we're right in the midst of looking at what's called fast track to be able to negotiate free trade agreements without any input from Congress once these agreements are made. And free trade agreements, the idea is to open up foreign markets to U.S. exporters, to reduce barriers to U.S. exports, to protect U.S. interests, enhance the rule of law, for the free trade agreement partner country, foster a stable environment, and to make it easier for U.S. companies to export their services. This all sounds well and good. And it is, in many ways. Except when you look carefully at this, to a large extent, what we're talking about is protecting U.S. interests and reducing barriers to U.S. exports and to open up markets for U.S. exporters. Now remember, the Farm Bill just passed, and one of the things that you'll remember about the Farm Bill is the Farm Bill is filled with subsidies. So what we're talking about is creating a level playing field with one of the people who is playing having huge subsidies, and these poor countries trying to compete, and they can't. And so what happens is that these countries, Jamaica, Mozambique, they lose their industries because they can't possibly compete with a level playing field and countries that either have subsidized products or they have products that are so much more advanced that there's no way that they can compete in terms of the marketplace. Some of the potential health impacts of these free trade agreements are expanding patent protection with unaffordable drug costs. In the case of HIV drugs, I've told you the story about Florencia, where she, in fact, was able to take advantage of these drug costs because in 2002, the drug costs went down because of force against Big Pharma. The WHO and others have estimated that 8 million lives were lost because of the delays of reducing the prices of these drugs. Had they been reduced in 1996, when they first came out, 8 more million people would have been saved with the same kinds of. So that's a huge number of lives that have to do with patent protection. And what these trade agreements do, for the most part, is that they homogenize issues like patent protection so that patents across the world won't be different from one country to the other. The reason that these drugs were possible in 2002 at a price that was 100 times less than the prices that the drug companies were asking for was because India had patent laws that were developed in the 60s and the 70s. But the rules that India has now for patent laws actually would restrict and probably prevent them from doing what they did in 2001, 2002. So it has huge implications. Just recently, we heard a talk where there was a drug called, I think, Naxavar, an anti-cancer drug. And this anti-cancer drug is a drug that sells for $65,000 a year. Very good cancer drug, $65,000 a year here in the United States. And that cancer drug, that India, one of their pharmaceutical companies, was trying to make that cancer drug. And the U.S. company and the U.S. trade representative are going to bat at a hearing next week in the International Trade Commission to discuss what's going to happen with that cancer drug and whether India is going to be able to make this cancer drug legally against the patents of the American company. Actually, it was Bayer, so it was a Swiss company. The CEO of Bayer said, this drug was not made to treat Indian patients. This drug was made to be used by people from rich countries who can afford it. He was actually quoted as saying that. This is the kind of thing that some of these trade agreements get us into thinking. That is, thinking about medicine and public health as an issue that is really related to money. Other aspects of trade agreements are that weaken health regulations. We know that in Thailand and other places that they were unable to regulate tobacco in the way that we felt was appropriate, mine and factory safety, that we have losses in jobs with low-income country industries have to close when they compete with subsidized goods, as I've talked about before. And then issues of non-living wages. Companies leave countries when the wages and when labor unions, if they happen to exist, increase the wages such that it's cheaper for them to go to another country. So the summary of what I've been trying to say is that health technologies have made a huge difference. That the technologies around AIDS, around TB, around malaria treatment, immunizations, maternal child health interventions, they've been tremendous. And I'm very proud and I'm very happy that we've gotten to this point. But that the biggest challenges right now to global health and to achieving global health is that group of 50% of Africans who are still in poverty, or the group of Asians and Latin Americans who are still in extreme poverty. And the process of their moving out of that poverty is going awfully slowly, if moving at all. And that the neoliberal strategies and market militarism are often drivers of poverty and inequality. If they limit the government capacity to either provide equity strategies by financing or other issues, to protect jobs or conditions, or to allow labor unions to function, or to protect the environment, including climate change. Every one of these issues has the potential for limiting government's opportunities to be able to deal with the really critical issues of global health. I like this slide because I think it epitomizes what we're doing, is that, how can we promote equality while still retaining our advantage? And to a large extent, that's kind of where we are in these days. It's a situation where the rules are made around international finance, around international trade, around the wars that we fight, that relate to the powers that we know exert themselves in Washington or Paris or London. And at the same time, we feel and genuinely that we want to achieve more equality. And it's contradictory. The other piece that I think is important is that this isn't necessarily a north-south issue. Because these are issues that we see in this country all the time, where we have the same divisions between the rich and the poor in this country as we have in the South. So it's not like we have the United States oppressing Mozambique or Nicaragua. We have issues around rich and poor in both countries, in both situations. Now, there are encouraging signs. Gordon Brown, in 2009, while he was still Prime Minister of Great Britain, said that the age of the Washington consensus is over, that neoliberal consensus. What's needed is a new consensus incorporating moral values. And I felt this was very positive. There have been anti-neoliberal movements in Latin America. Over 10 presidents have been elected explicitly on anti-American, anti-neoliberal policies. And the word neoliberal, or neoliberalismo, is in fact a very well-known word in Latin America and in Africa. WHO's universal health coverage, which is the newest initiative over the last several years at the World Health Organization, is a rights-based approach to health care. It's bringing us back, as Margaret Chan has suggested doing, it's bringing us back to primary health care of the 70s. That whole issue, she said, we have the recipe, we have the roadmap to achieve health for all. And we can use the same one. Jim Young Kim, who wrote the book Dying for Growth, which was a critique of the neoliberal approach to development, is now the president of the World Bank, which is as big a contradiction as I've ever seen. And Jim is going to have a tough time, frankly. He's a friend. He used to be at Partners in Health. He was part of the activist group pushing for a right to health. And now he's head of the World Bank with all those economists. So we'll see how he does, but that's an encouraging sign. President Obama just recently said global inequality is the quintessential challenge of our time. Pope Francis has made outspoken criticisms of growing inequality. And just a couple of days ago, Bill de Blasio, who is the new mayor of New York City, has announced a campaign to combat income inequality. So this is a problem here and around the world, and people are starting to take notice. So what are the things we can do to improve health? And I'll end on these sort of a call to action, if you will. And the first thing I want to talk about is the whole idea of how we can get these issues on the global health agenda. How do we frame the debate? What kind of perspective do we bring to the table? And what I would suggest is that, to a large extent, the perspective that we have in teaching global health is one that is kind of, it's like almost the Seattle global health approach. You know, we've got this wonderful South Lake Union center of technologies that I find really, really uplifting because we're developing all these technologies. We've got the Gates Foundation, which is putting money into combating diseases. And when you combat disease, you know, you're dealing with a very specific thing. But I consider it sort of a sanitized version of health and health care. When you look at technology and disease and not the underlying factors that address those diseases. So I think we have to reassess what we're doing in terms of how we frame the debate. And I don't think we can count on the press anymore. Because the press is now become a bit of a corporate mouthpiece in many parts of the world because of their economies. I don't think we can count on foundations as much anymore because they need to think more broadly, and sometimes foundations are not completely independent of their parent organizations that created them. I think we need to think about think tanks. I think we need to critique alternatives. And then finally, that brings me to the role of the university. What is the role of the university in this? What can universities do? You know, there's sort of a sense of us as faculty and students and staff of the university that we have to kind of remain credible. We have to remain neutral. We have to be dispassionate. And the whole idea of advocacy seems like a, you know, it's a non-starter in a university setting. And that as scientists, we need to be objective and reduce bias and subjectivity. But I would suggest that every one of us who's here is here because we have biases. We have hidden biases. And those biases are partially because we care about issues. We think things are important. We have a passion for learning and a passion for discovery and to make the world a better place, usually. There's usually a link in our own minds. And that a lot of the huge interest in global health is about this passion to make the world a better place. I think universities have long been focal points, in fact, of social action, even though sometimes we don't think so. When I grew up, the Vietnam War was all about social action, civil rights movements. Universities were very much involved in both the anti-Vietnam War and civil rights. I talked about the Harvard Consensus Statement and how important that was for HIV. And HEI and the University of Washington have actually been very involved in some of the issues around advocacy around AIDS treatment. And as journalism struggles, my sense is that somebody needs to take some of the responsibility for independent investigation. I think universities need to step up. They need to step up into this political sphere. And as Russell Wilson says, you know, if not us, you know, who else? Why not us? If you look at the textbooks in global health, I looked at the textbooks, and of all of these 6 textbooks of global health, not only one of them addressed some of these social justice issues. Okay? And that was the European textbook. The American ones did. These are the social determinants of health. This is the way that I try to describe health with underlying determinants, intermediate determinants, proximate, and disease determinants. that we tend to operate here in the diseases, and sometimes we get into the proximate conditions. Occasionally we get into these intermediate conditions, but very rarely do we step our toes into this underlying stuff because it's messy and it's political. And my sense is we have to do that as part of our stuff. Pope Francis said, while the income of a minority is increasing exponentially, that of the majority is crumbling. This imbalance results from ideologies which uphold the absolute autonomy of markets and financial speculation, and thus deny the right of control to states, which are charged with providing for the common good. He said this last year. I think it's very encouraging to see him say this. Martin Luther King, a long time ago, said something that I think is just as true today. He said that compassion is more than just flinging a coin to a beggar. An edifice which produces beggars needs restructuring. A true revolution of values will soon look uneasily on the glaring contrast of poverty and wealth. It will look across the seas and see individual capitalists of the West investing huge sums of money in Asia, Africa, and South America, only to take the profits out with no concern for the social betterment of the countries and say, this is not just. Finally, I want to end with a little update on what happened to Luz, Mabel, and what happened to Florencia. Luz Mabel, this is a picture of her taken in 2003 when a photographer went back to see it. It just so happened that the photographer published a book that included this, so I was able to talk to him. She is doing well, but she didn't go to high school because of what I showed you in Nicaragua. Because high school is basically, had she been in school 5 years earlier, she would have finished high school and probably become a nurse. She works at home, she's living happily, and now she's caring for her own baby. In the case of Florencia, this is Florencia's daughter, Ruth Powell, and her grandson, Lula. This is actually, I just talked to Florencia, as I told you this morning, and Florencia told me that of her 4 kids, only one is still in the university, the other 3, or 2 are still in the university, 2 have completed their university training. Ruth, here on the left, is in her final year of medical school. And Ludlin is just like you could imagine in that picture. So what I would suggest to you is what we need to think about is how we're going to create a society that's going to allow the kids of these people to live the lives that they can. Thank you very much. Thank you.
I'm Howard Frumkin, the Dean of the School of Public Health and an active member of the Steve Gloyd fan club who happens to be tethered to Steve at this point by having 1 microphone. Steve, I think I speak for everybody in the room when I thank you and congratulate you for this talk. You exemplified not only the best of public health, but the best of higher education here at our university.
Thank you.
You were grounded in morality, the human rights framework that was very moving, and you were grounded in science, and you based a lot of what you told us on data that you showed us. You gave us a global perspective that spanned the world, and you were granular and specific and based in love and compassion for individual people. You were idealistic if you've been for 30 years, and you were oriented toward a specific, hard-nosed commitment to getting things done. And you've demonstrated just how much a beautiful shirt can do for a gentleman's image.
Thank my wife for that.
So we have just a few minutes before we'll be inviting all of you to join us upstairs in the Walker Ames room for a reception. There are microphones to the side of the room, and we do have time for a couple of questions or comments. So if you have one and you'd like to step to one of the microphones, please do that. Please identify yourself when you speak, and please resist that urge to deliver a speech masquerading as a question.
I'm Mohammed Al-Birer. I'd like to thank you, Steve, for the speech. And before I ask my question, I'd like to say that I'm an MPH student, and I've taken Steve's class in the fall. and I'm fortunate to be TAing for his class for the undergrads. And so I've been listening over and over to what he has to say, and every time I find it inspiring, and it opens so many questions to me. Not that I do not understand, that's the thing that... So I feel my biggest question is, the picture for me, it looks clear of what needs to be done, but I always ask myself as a physician in my home country, I feel that being a physician gives you some sort of power, and I feel I have the responsibility out of being here and learning what you have to say and what I get from the opportunity of being here. What is it that I could do when I go back? I'd like to link this question to your experience when you were in Mozambique. You worked as a physician over there, and you've seen all the factors that you've been describing come into play in availing health for all. So what is it that you think that when I go back, I could do to help, waiting for the policies to change, waiting for the new ideologies to change the world, and health becomes available for everyone over there? Thank you.
Thank you, Mohammed. Very nice question. I was afraid as you were going through the question that you're asking me something that would take me an hour to ask, but the last piece made it very clear, is that you asked, what do you do while you're waiting for policy to change? And what I would say is that policy change happens because of people like us who are in this room, who decide that we want to reframe the questions, we want to put different kinds of evidence, scientific, based on science and based on moral principles, and make sure that it's part of the debate. Make sure that we get out there. Every one of us should be writing op-eds. Every one of us should be discussing the kinds of issues that make a difference in our moral universe, because if we don't, who will?
My name is Mary Proudfoot, and I'm a registered nurse. And my question is, where is the most effective place in terms of affecting public policy? Part of my frustration has been that my representatives support the kinds of things that I believe need to be done in terms of healthcare and things along that line, but there doesn't seem to be any kind of a forum to speak to those people who don't necessarily support sort of universal kinds of healthcare issues. And I'd like to know of any way that we can speak to some of those people as well.
Well, my sense is that you can work anywhere. And like when we were discussing this before, that there are things that you can do that have huge impacts on health right here in Seattle that still need to be done, even if our representatives here happen to be, quote, on the right side. There's a $15 minimum wage bill that's out right now, which will have, I think, enormous consequences for people's health. And it's something right here. It's very important. If we do it here in Seattle, it's going to make the whole world turn its head and look at what we're doing, and it's going to have a huge impact. But I also think that if our focus is on, in my case, my focus is on Cote d'Ivoire and Mozambique or in places like that, oftentimes policy shifts by talking to people and stakeholders who are in those countries, which is part of the work that I do. But I also think that as much policy can occur by dealing with Washington, D.C. So for instance, in the case of AIDS treatment, our Congress was a virtual slug in terms of its movement, towards progressive change around AIDS treatment. And in fact, we actually even had a hard time getting Jim McDermott on board with universal AIDS treatment until we talked to him maybe 3 or 4 or 5 times, trying, with a changing environment. And now he's one of the most fervent activists around AIDS treatment from a right to health, from a moral point of view. So part of it is picking an issue that's appropriate at that point, that's going to make a difference. I think there's always there's always room for movement around these issues. And the second piece is just to have incredible patience and persistence, because nothing changes very fast.
I have one last question here, please. Go ahead.
sir, for a wonderful lecture. I've been upstairs there and I listen attentively to your presentation. I have a question and a comment. First of all, I'm wondering, you asked in the last slide, what can universities do to improve the situation? I've penciled down a few points here. That universities need to step up to the challenge of global health development. They can help develop drugs or vaccines without any patent protection, thereby making it cheaply available to those who want to make them commercially available at inexpensive prices. Universities can lower tuition costs and access to education for the poor. Universities can embrace alternative cure to diseases, embrace and examine claims of cure of diseases by alternative health workers. I believe you don't need to have a MD behind your name to be able to have an insight to bringing cure to the disease. For instance, I'm aware of a Dr. Joe Wallach who trained as a vet doctor and now is a certified nutritionist based in Utah. He's the owner of the longevity program. He has claimed to reverse so many diseases, diabetes, high blood pressure, hypertension, all kinds of things that regular medical doctors will tell you they are irreversible, that cannot be cured. So my challenge is, why can't the formal institutions like universities embrace these claims, examine them, look at the veracity, whether they are actually true or not, and if they are true, give them the support they need so that people who actually need the cure can have access rather than pay several visits to the MD who will only examine them and talk to them and without really giving them the cure that they need. Thank you.
Thank you for the question. I think to a large extent you've answered your question, which is that, that we should all be involved in studying and evaluating these kinds of interventions, whether they're community-based or health systems-based, technological or not. And I think that's one of the really wonderful things that universities can do, and to look at it from every aspect possible. There's been lots of work on community-based care and traditional care, some of which is very useful, some of which may be less useful, and I think that it's the responsibility of all of us to try to get to the bottom of how efficacious these approaches are.
Please join me in thanking Steve for a wonderful presentation.